Hi, everyone. This is Kristen Whedon. I serve as president of the United Porphyrias Association, and I am joined today by Dr. Bruce Wang, porphyria expert at the University of California, San Francisco. Welcome, Dr. Wang.
Thank you. Good to be here.
We had a live Facebook event on February 24th in the Porphyria Together Facebook group. The recording of that is in our Facebook group right now in Porphyria Together. But we had so many terrific questions from the patient community, and we didn't have time to get to all of them. So, Dr. Wang, you have generously offered to record some of these questions together with me today to share with the broader patient community. So I do want to share, thank you for that. I do want to share that we are going to do additional live streams soon. Our next one will be on May 11th with Dr. Amy Dickey from Massachusetts General Hospital. And you can join Porphyria Together at any time to be able to take part. But thank you, Dr. Wang, again for being here today. We are going to go through questions, and the first questions we're going to ask you are general questions about the porphyrias, and we're going rapid fire. Y'all ready for this? All right.
All right, let's go.
Okay. So, Dr. Wang, the first question is this: are there current treatments for the porphyrias?
So yes, there are, and I'm going to maybe talk about this by the specific type of porphyria. So we may discuss some of these again with later questions. And I'll first start with what are the approved treatments for the porphyrias. So for the acute hepatic porphyrias, primarily affecting those patients with AIP, variegate porphyria, and hereditary coproporphyria, there are two approved treatments for those patients who are experiencing acute attacks. There's panhematin in the United States and heme arginate in Europe and most other places in the world. For those patients who are having frequent recurrent attacks, typically defined by, on average, having 4 or more attacks per year of acute attacks, there's a second medication called, the trade name is Givlaari, that is used for prevention of acute attacks. For EPP patients, there is one approved therapy. The trade name is Scenesse. That's available here in the United States as well as in Europe. It's a subcutaneous injection given typically once every 2 months. There are some additional medications that are currently in therapeutic clinical trials, but for EPP, but not yet approved for treatment. For porphyria cutanea tarda, there are two primary treatment methods for patients. The first is therapeutic phlebotomies to lower total body, but more importantly, liver iron levels. And patients can also get low doses of hydroxychloroquine, which directly lowers and gets rid of porphyrin levels within the liver. For patients with CEP, although there are not necessarily approved therapies for CEP, some of the ones that are fairly widely accepted are for those patients with severe CEP who have hemolytic anemia, transfusions with packed red blood cells. In fact, hypertransfusions to keep the hemoglobin levels high is shown to be effective in suppressing heme production and then accumulation of the porphyrins in CEP patients. And for CEP, also the curative treatment is a bone marrow transplant.
Great. Thank you for discussing current and potential treatments. Now we have the next question is from a patient in the UK who would like to participate in research, and they'd like to know if this is possible.
Yes, there is. And specifically in the UK, I would direct the patient to contact folks. There is a patient organization in the UK, the British Porphyria Association. They work with several porphyria centers. In fact, in the UK, there is a national acute porphyria service, which I believe consists of primarily 4 main academic sites that provide treatment for acute porphyrias. Most of those centers have some experience with the cutaneous porphyrias as well. So that's where I would direct this patient to go for information.
Great. And we can certainly help getting them in contact with the British Porphyria Association. Okay, our next general question, which porphyrias cause anemia, or do they all impact and cause anemia?
Yeah, it's a good question. It turns out that the porphyrias that typically are associated with anemia are the ones that primarily affect the bone marrow, and not the ones that primarily affect the liver. So the two that are oftentimes seen with anemia are first, congenital erythropoietic porphyria, CEP, and in severe cases of CEP, patients have anemia, and a particular type of anemia called hemolytic anemia. And the reason is because of the extremely high accumulation of porphyrins are toxic to red blood cells and causes the red blood cells to lyse. And that's the cause of anemia in CEP. In patients with EPP, this applies to both patients with classical erythropoietic protoporphyria as well as those patients with X-linked protoporphyria. Somewhere between a third of 40% of those patients also have anemia. It tends to be a milder anemia, typically associated with iron deficiency. So those are the two types of anemia where we more commonly see association with anemias.
Great, thank you. And our last general question, for the porphyrias that have photosensitivity or phototoxicity, the question is our sensitivity to sunlight, does it have to do with something about our photoreceptors? That's the...
Yeah, so I'm not familiar with the term photoreceptors. There are photoreceptors in the body. They're present, though, only in cells in the eyes and specifically in the retina. And these are receptors on a couple of cell types within the retina that actually gives us our vision. Other than that, the sunlight sensitivity that we see in the porphyrias are actually primarily due to the chemical properties of the porphyrins themselves and not really to cellular properties of sunlight absorbance. Now, having said that, I should mention that the sensitivity does have something to do with how well the light penetrates our skin. And so, additional barrier protection, basically physical, that's why physical barriers work. That's why we recommend that patients with cutaneous photosensitivity with porphyrias wear long sleeve clothing and wide brim hats. It's that actually provides a physical barrier to block off sunlight. And incidentally, that's also how the mechanism of action of the medication Scenesse, for example, in EPP patients, is that those medications induce our pigment-producing cells in the skin to make more melanin pigment, which essentially just acts as somewhat of an additional physical barrier to sunlight penetrance into the skin.
Okay, great, thank you. We're going to talk about the acute hepatic porphyrias now and answer some questions that patients had directly for you, Dr. Wang. The first is, can a person develop porphyria, specifically an acute hepatic porphyria, from toxic mold exposure or toxins?
Right. I think this depends on the type and actually the route of exposure. So for the acute porphyrias, the attacks are really induced when the liver has to make more heme. And when it comes to toxin exposure, and specifically toxic mold exposure, oral ingestion of toxins, including molds, may induce acute attacks because oral ingestion of toxins, eventually those toxins are absorbed across the intestinal membrane, and it is actually the liver's job to metabolize and break down these toxins so that we can eventually get rid of them. And that process sometimes will involve the induction of heme production within the liver, and that could induce acute attacks. Now, other types of exposure, for example, inhalation exposure, skin exposure, these are very unlikely to induce hepatic heme production, and so are very unlikely to induce acute attacks.
Great, thank you. The next question is from a person who has AIP, or acute intermittent porphyria. And the question is, could my AIP have caused my kidney issues?
So there is a connection between AIP and decreased kidney function. The best data shows that patients with AIP, in particular symptomatic AIP, have decreased kidney function as measured by the glomerular filtration rate. Now, the degree of kidney damage that occurs in acute porphyria patients overall tends to be fairly mild. It's pretty uncommon for patients to develop end-stage renal disease and need, for example, hemodialysis as a result of AIP. But there is clearly a connection. There are also a subset of patients with AIP who have a particular mutation in a gene called PEPT2. This gene encodes for a transporter for actually chemicals, including ALA, within the kidneys, the kidney tubules in particular. And those patients with a particular mutation in the PEPT2 gene have really high accumulations of ALA within their kidneys. And those patients are at even higher risk of developing kidney damage than the typical symptomatic AIP patient.
Great. And for those who may not know, ALA stands for?
ALA stands for delta aminolevulinic acid, and that is actually the first precursor that is made in heme biosynthesis. And ALA is always elevated during acute attacks in patients with acute porphyrias.
Great. Thank you. Okay, Dr. Wang, what resources would you recommend for my care provider and myself to learn more about porphyria, both types, symptoms, treatment, and mechanisms of action? I got a great website I'm sure you might mention.
That's right. So I will mention two particular resources. The first is I would direct folks to the Porphyrias Consortium website. This is through the Rare Diseases Network. And that's where you can find, and as well as providers can find the type of information that was asked about. The other place is the United Porphyrias Association at porphyria.org, which you could see in the Zoom background over here. And that will have that information, as well as information about drug safety, for example, for patients with acute porphyrias.
Thank you. Okay. This next question is from a patient with HCP, hereditary coproporphyria. Are there natural ways to support porphyria for those that don't want to take drugs?
Right. Well, there are, unfortunately, only two drugs available for treatment in patients with hereditary coproporphyria. This applies as well for patients with variegate porphyria and acute intermittent porphyria. The first is treatment during acute attacks. That's, again, panhematin here in the United States, heme arginate, most other places in the world. And then one for treatment for those who have frequent recurrent attacks. That's the medication Givlaari. Now, if you're experiencing acute porphyria attacks with elevated levels of the heme precursors, we mentioned ALA, the other one is PBG or porphobolinogen, and you're having symptoms, you really should be treated with panhematin. There are really no other effective alternatives to panhematin for stopping an acute porphyria attack. So it's very difficult to manage those that severe episodes without giving heme, and you run the risk of having a prolonged and more severe episode that may lead to more permanent neurologic damage. Now, there are some things that I think all patients with acute porphyria should know about so that they can decrease the risk of having an acute attack. Now, there are certain triggers of acute attacks that are fairly well known and that can be avoided. So, for example, alcohol intake, tobacco use, those should be avoided. The uses of medications, there are certain medications that are known to be strong inducers of cytochrome P450s. I'm not advocating for absolute avoidance of any medication that increases the production of heme in the liver, but that patients should be aware that taking these medications might increase the risk of acute porphyria, so that you make an informed decision about the potential benefit of taking that medication for whatever other medical condition that you may have, and the potential risk of increase of having an acute attack with it. But I think all patients with acute porphyrias should have and know about access to treatment if you are to have an acute attack, because I think that's really important to prevent developing irreversible permanent neurologic damage from an attack.
Understand. Great. Thank you. Okay, this next question. This patient, and this is a patient with VP or variegate porphyria. It's actually from a patient named Kelly. She says, I get parasomnia where you smell and taste something that is not there during my attacks. When I start panhematin, it went away or it goes away. Is this a normal symptom of an acute porphyria attack?
Right. So, Kelly, I think what we are describing is a condition called phantosmia, or basically olfactory hallucinations. It's where you're exactly like you described, you smell and perhaps taste things that are not there during attacks. And this is caused by dysfunction of your olfactory neurons that are there in your nasal and oral pharynx that connect to the brain. There are, it's not a very well studied area of neurology, but I think during acute attacks, high levels of ALA and PBG, primarily ALA, can certainly target olfactory neurons. So this is not a common set of symptoms that that I typically see in my acute porphyria patients, but I think that this is well within the possibility of ALA effects, that it may affect, in your case, your olfactory neurons, and it leads to these olfactory hallucinations. And I'm not surprised then that once you take panhematin, lower the levels of ALA and PBG, this goes away because your olfactory neurons are no longer being damaged and triggered by ALA.
Okay. Thank you. The next question is about another symptom of acute hepatic porphyria. And the question is, well, first, this statement, one of my symptoms during an attack is passing out. And the question is this because the pain is so intense during an attack, or is there something potentially more to it?
Yeah. So I think there's a couple of different possible etiologies of passing out during an acute attack. Our body's actually nervous system, especially the sympathetic nervous system, responds to pain. And severe pain can elicit a very strong sympathetic nervous system response that may lead to somebody passing out. Additionally, the sympathetic nervous system itself is affected during an acute attack. Patients get increases in their heart rate and high blood pressure, and that by itself, in some patients, may also lead to passing out. And then lastly, the central nervous system is also affected during acute attacks. And for example, some patients develop seizures, and that may be felt as a passing out episode. So there are a number of different ways where patients can pass out during an acute attack. And they're all actually likely related to the underlying pathology of high levels of ALA and its effects on the nervous system.
Okay. We have another symptom from a woman who says, my whole body starts shaking uncontrollably when I'm in the ER. Is this normal?
Yeah, we see this relatively commonly in other patients, other acute porphyria patients during acute attacks. And again, some people have that reaction when they are experiencing severe amounts of pain. Acute attacks, high levels of ALA also affect our motor neurons, our sensory neurons, and that may cause, muscle twitching that may contribute to the shaking. So this is a fairly common set of symptoms that we see, and I think is also definitely related to having high levels of ALA during an acute attack.
Great. I think this patient will feel good that this is a typical symptom. Okay. The next question, can porphyria cause a mental condition? My daughter, as well as others in our family, have AIP, or acute intermittent porphyria, and my daughter has some mental health issues. Is this due to the porphyria?
Yeah, so I think there are two ways where acute porphyrias can contribute to mental health symptoms and other effects. So first is that during an acute attack, again, the central nervous system is affected. So patients oftentimes will complain of mental status changes in the middle of an acute attack. Now, there are also separate from that patients who have, especially those patients who have frequent recurrent attacks, also have a actually fairly high chance of having additional mental health diagnoses and symptoms. And this is, I think, due to a number of factors. Number one, the severity of the disease, severity of the symptoms, the frequency of the symptoms. I think there's probably also a fairly significant contribution to the fact that most patients with acute porphyrias and have frequent symptoms probably had a very long diagnostic journey and the difficulty in getting the diagnosis done. And for some patients, also a lack of treatment that's available have also very likely contribute to the development of additional mental health issues. So I think there's multifactorial, but is very commonly seen especially in symptomatic acute porphyria patients, and especially those with frequent recurrent attacks.
I look forward to your response on this one. The question is, how do I get my small town ER or emergency room to realize that this is an emergency and this is someone when they're in an acute porphyria attack? She comments that they leave me in the waiting room until I pass out, then they finally come to get me.
Yeah, this is unfortunately very commonly, seen experience in our acute porphyria patients, and this may not, be this may be true even in large cities and urban areas, and this is in large part because we're dealing with a relatively rare disease, and most other physicians don't have experience with it, and the ED physicians also do not have much experience with this. So I think in my experience, probably there's two things that, in my experience, can tend to help with this. The first is if you have a porphyria physician, a porphyria expert, that you can get involved in your care and have some information from the porphyria expert. It could be a written note that you can carry along with you. Even better is if you have contact information from the porphyria for the porphyria expert. I've many times called EDs while my patients were there and asked to speak to the ED physicians, and that always expedites the process. The second thing that can help is actually, finding it. It takes some trial and error, but actually finding and sticking with a single ED, and so that you develop some familiarity with the ED staff and the ED providers there. That over time, I think has from my patients have told me that also helps reduce the chances of this kind of scenario happening, where they're not treated promptly and not, unfortunately, sometimes not taken as seriously, because when the ED physicians do an exam and do laboratory testing, imaging testing, usually everything comes back fairly normal.
Fortunately. Dr. Wang, can you give any suggestions for AIP and VP patients? Well, really acute hepatic porphyria, which encompasses all four types of acute porphyria. Can you give any suggestions for these patients having to have surgery? And is there anything we can all do to get the surgical team on board for precautions and to run blood work afterward to check for an attack? And this question comes from a patient who had previously been totally paralyzed on one side, and on her face post-surgery, it was a thyroid removal at that time. And what she shared is that nobody on the team worked directly with anyone who really knows porphyria and they don't know what they don't know, and didn't seek to find out. So what suggestions would you give for a patient on the cusp of surgery?
Yeah, so a couple of things there. I think first, I think all of our acute porphyria patients, I would recommend that you get some baseline evaluations with urine ALA and PBG measurements so that you can have an assessment of what your relative risk may be for developing an acute porphyria attack. Those patients who have at baseline, when you're feeling your normal self, have high levels of ALA and PBG, I think maybe at higher risk of having an induced attack during something like an elective surgical procedure, where you may go through prolonged periods where you're not taking in much nutrition and you're getting anesthetic medications that may cause increased heme production in the liver. And then also in the post-surgical recovery period, you may have additional stressors that may increase your risk of an attack. So I think getting an assessment of how high is your risk of having an attack, I think is always helpful. And I'd recommend that all of our patients do this. And then in terms of connecting the surgical and the anesthetic anesthesia staff so that they are aware of the potential issues that you may face as an acute porphyria patient. Again, as we talked about with the ED providers, it is really helpful if you have a porphyria physician who I think, I've done this a lot, and I know that all of my other porphyria colleagues do this on a regular basis, and we're always more than happy to do this. Connect your surgeon or anesthesiologist to us. And most, I think, those surgeons and anesthesiologists, if you provide them with a resource and a contact, they're more than willing to reach out to us because they don't want to have a complication on their hands that they don't know how to manage either. And then the last thing, sometimes in my patients who have frequent recurrent attacks or who I think are at high risk of developing an attack, these are things that we can manage together with the surgeons and the anesthesiologists. For example, I've asked that my patients be admitted to the hospital the night before even an elective surgical procedure, so that they're in a monitored setting, that they get an IV infusion of some dextrose, so that their body isn't in a prolonged starvation state. And there's a plan in place so that people know what to watch for, and that if symptoms arise, that there's availability of panhematin, let's say in the postoperative period, to treatment of an attack.
Great. And I have connected many physicians to experts of the Porphyrias Consortium, both you and others who have been so dedicated and generous with their time in consulting in all kinds of scenarios. Okay. The next question: why do some drugs not go with my body and cause an attack?
Right. So most drugs, these are foreign chemicals of the body. These are not chemicals that our body normally sees, and so our body has to get rid of them. And the liver is the main organ that is responsible for breaking down and getting rid of toxic chemicals. And most medications involve quite a lot of chemicals, again, that are in some ways toxic to the body. And so certain chemicals, the way that the liver gets rid of them is by making more heme, because they require sort of machinery, if you will, within the liver, using the cytochrome P450 set of enzymes to break down the chemicals. And these enzymes require heme as a critical component to the machinery. So that's why certain medications are well known to increase the risk of having an acute porphyria attack. So I don't think it's necessarily a genetic predisposition in some patients that makes it so that when they take certain drugs, they have an acute attack. Although that may play a little bit role into it. I think a lot of this, we're talking about the effects of the drug on the liver and how much it induces heme production in the liver. And that's why some drugs induce attacks and other drugs have much lower risk of inducing attacks.
Great. And if there is a medication that a patient that isn't on a drug safety list, accessible on porphyria.org, they can always contact us, and I go directly to you or one of the other experts for guidance. Correct.
And actually, if I may, maybe I'll use this opportunity to also put in a little plug and encourage people to help contribute to this area where I think we need a lot more information, especially with newer drugs where there's very little data. So there are a lot of anecdotal reports about drug safety in porphyria, but there's very little actual objective evidence for us, for me to really be able to answer a patient when they come to me with a question about specific drugs. So we have an ongoing clinical study where we ask patients who have experiencing an acute attack after taking a medication to fill out an online form and to include information about the kind of drug, what drug they took, how long they have taken this drug, the dose of it, the symptoms that they experience, and preferably also some biochemical information about whether or not they had an increase in their ALA and PBG levels. And this is going to be an ongoing study where we're going to try to collect as much information about all different kinds of medications as we can. There are talks we're in discussion with our colleagues in Europe to expand these questionnaires and availability to patients in Europe as well. And the hope is that through this, with our patients' participation, we'll finally be able to gather enough information to give more objective risk assessment to the safety of drugs, and especially newer drugs that our existing drug safety databases for porphyria don't have any information about.
Agree. And this information is just so badly needed. Access to the study that you just talked about is on two places that you mentioned earlier, both porphyria.org in our research section, but as well as the Porphyrias Consortium website. Or
Correct.
Patients can also always just contact UPA and we'll guide you to it.
Yeah.
Okay.
Thanks for pointing that out, Kristen.
Yeah, absolutely. The next question is, how does perimenopause impact HCP and VP?
Yeah, so, and I'll probably expand this to include patients with AIP as well. So, so in women, 90% of patients who experience acute attacks are women. And so there's a clear connection to hormone levels, and especially changing levels of hormones in the body, to having acute attacks. And a lot of this is because, again, the liver is the main organ in the body that breaks down and helps get rid of hormones within the body, including estrogens and progesterones. And of these two hormones, estrogen and progesterone, we think that is changing levels of progesterone that has a greater impact or a higher risk for inducing acute attack. So in the perimenopausal period, this is a period of time where the levels of hormones, especially estrogen and progesterone, are changing in the body. And so we see actually changes in both directions. Some patients start experiencing more attacks during the perimenopausal period. Other patients who are having frequent recurrent attacks may start seeing a decrease in their attack frequency during the perimenopausal period. But I would say in general, that period of time where the body's hormone levels are actively changing is a time where you're likely to see changes in the frequency of acute attacks. And again, it could go in both directions.
How difficult is it in your experience for someone with acute intermittent porphyria or an acute hepatic porphyria in general to work full time?
Yeah, so well, maybe I'll answer the question in this way and talk a little bit about the general sort of epidemiology of acute porphyrias. So if we talk about all patients, all people who have who carry the genetic mutations for any of the acute porphyrias, and so who may be at risk of developing acute porphyrias, that's actually probably a much larger number of people than we typically think of as associated with acute porphyrias. So somewhere around 1 in 1,500 people worldwide will carry a mutation for acute porphyria. And the vast majority of these people, if I take 100 people with these mutations, 1 or 2 of them will ever develop symptomatic acute attacks. And so for the other 98, 99 out of 100 people who have mutations, and you may notice that I sometimes hesitate to call people with mutations patients, because most of these people never experience any symptoms from the acute porphyrias, and they may not even have any of the long-term complications from acute porphyrias. So
should that
most
patient
people,
community be avoiding the triggers that you described earlier?
that's a really good question, because I would say those patients be aware of what an acute attack feels like. And those patients should still be careful about drug safety. Not that they should, I would say those are patients who have very low risk of having an induced attack, but it's not zero. So that they should be aware of what an acute attack is, so that if they are to have it, then that it could be treated promptly. But those patients, I would say that the risk of having an induced acute attack with even a medication that perhaps was a stronger inducer of acute attacks, they would just have lower risk. And so I would assess the risk-benefit analysis a little differently in those patients than ones who have the mutation and have also experienced it. And then on the other end of the spectrum will be those patients who have mutations, have experienced attacks, and have frequent recurrent attacks, and probably high levels of ALA and PBG even at baseline. Right. So it's about the relative risk assessment for patients.
And I think my probing question got you off the how difficult is it for someone to work full time?
Right. So again, just because you have a mutation in one of the acute porphyria genes, vast majority of those people never have acute attacks. And then now if I take 100 people who have experienced an acute attack in their lifetime, again, probably 90, more than 95 of those patients will only have a small handful of attacks in their life. And those attacks, if we really look at the circumstances around the time they had an attack, those are probably clearly triggered attacks. They had a concurrent severe illness. They started a new medication that was a very well-known strong trigger of heme production in the liver. They were undergoing a surgical procedure. There was some other very clear, unusual inciting event, and that attack is unlikely to have occurred sort of spontaneously by itself. Again, those patients generally will not have another attack in their lifetime. And assuming that the attack they experienced was, like most attacks, a self-limited attack, they are almost in all cases going to recover fully from that attack. And again, they probably will have likely fewer problems, if any, with acute porphyria in their lifetime. And those patients, again, shouldn't have any issues with being able to work full time. It's the small number of patients. Now we're talking about, it's not just 1% of everybody who has the mutation, it's 1% of people who are having severe recurrent attacks, who have attacks that have recurrent attacks. Now, these patients generally have more than 4 attacks per year. Each one of these attacks are very severe. Recovery from a single attack typically lasts weeks, if not months. And so one attack then bleed symptoms, and recovery bleed into another. And a lot of these patients have much more significant limitations on what they can do. And it may be difficult for those patients to be able to work full time. So it's a very long answer to saying that it really depends on the disease severity, but the vast majority of people who have mutations in acute porphyrias do not experience symptoms, and the vast majority of patients who experience symptoms have self-limited and only a few symptomatic episodes in their life.
Great. Thank you for that detailed response. So the next question, do you only test for high ALA and PBG with an attack, or can you do it at any time?
You can do it at any time, and I highly recommend that you check it at least once as a baseline to figure out what your risks are for developing an acute attack. But it is really very important that with every symptomatic episode that you or your physician suspect is an acute attack, that we should be checking ALA and PBG levels. And if you're being treated with either panhematin or Givlaari, that before every treatment, you should also check your ALA and PBG. Now, in terms of how we check for ALA and PBG, the levels are really high during acute attacks. So a random urine sample is more than enough. You do not need to do 24-hour urine collection. You also don't need to check for ALA and PBG in blood. It is very soluble in water and is present in high levels in urine. Okay, and then I also really recommend that patients also check a urine creatinine whenever they check urine for ALA and PBG. That makes it a lot more, makes the levels a lot more comparable from one testing to another. So my general recommendation is to check random urine samples for ALA, PBG, and creatinine, to do that at baseline at least once, and then with every subsequent attack and with prior to every treatment.
Terrific. Very helpful. The next question is clearly from someone in Scotland. And the question is there, or are you aware if there is a higher prevalence of HCP or hereditary coproporphyria in people from Scotland?
So I am not. There are, with HCP, there's not very well characterized founder effects, if you will, where that leads to a higher prevalence in a certain geographical area. Probably the best and the most well characterized founder effect is in variegate porphyria, and with a high prevalence in South Africa due to a founder effect from one of the original Dutch settlers to South Africa. But I'm not aware of founder effect in Scotland and specifically for HCP.
Thank you. And this is our last question under the acute hepatic porphyrias. And the question is from a woman that says, I had severe abdominal pain growing up that no one could identify. I figured out in college that kefir really helped, and in grad school was diagnosed with gastritis. So I mitigate my stomach pain with kefir. Could this also be part of porphyria?
Well, so the difficulty with diagnosis of acute porphyria and acute porphyria attacks is that the symptoms of acute attacks are not specific to porphyria. They could look like gastritis. They could look like gallstones. They could look like appendicitis. They could feel like endometriosis and all kinds of other kinds of symptoms. So the way to make the diagnosis is to check for high levels of ALA and PBG, and it is most informative to do the testing while you're feeling some of your symptoms. But again, if you're feeling symptoms regularly, even a baseline level is very helpful, because those patients who have frequent recurrent attacks have high levels of ALA and PBG even at baseline. So if you're feeling symptoms on a frequent basis and you check a urine ALA and PBG and it's normal, chances are quite low that you're having frequent recurrent acute attacks, and we should probably look elsewhere for an explanation of your symptoms.
Thank you, Dr. Wang. And that concludes our questions for today. We so appreciate you and your willingness to have these rapid fire responses to all the questions from the patient community. You are just a superhero in our eyes, and we're so appreciative of your time and expertise.
Sure, very welcome, Kristen, and happy to answer any questions that patients have.
Thank you. And with that, I want to share with the patient community that there's no need to wait until a Facebook Live session, that if you have questions about your porphyria or potential porphyria, you can reach out to United Porphyrias at any time on our website, through our email, info@porphyria.org, or give us a call. We will be having another Facebook Live session on May 11th, so patients can join the Porphyria Together Facebook group to listen live, but we certainly don't have to wait until that time to get answers. The Dr. Wang and our other porphyria experts are almost all available, always available to us. But especially thank you, Dr. Wang, for this as the follow-on session to our live session back in February. You are beyond appreciated.
Sure. You're very welcome.